Hello, this is Andy Shore from Washington, D.C. with your pulmonary and critical care update. There's one major theme in the literature this week that I'd really like to review with you, and that focuses on venous thromboembolism and thromboprophylaxis. First, this week we saw the publication of the 8th edition of the American College of Chest Physicians Guidelines for Venous Thromboembolism. This book is essentially now a tome. It weighs several pounds, for lack of a better term, and is actually much updated from the last iteration 3 years ago. In fact, we've now had an ACCP consensus document for over 20 years, and the document has seen a number of major revolutions and also evolutions. This year we see a number of changes, not only in terms of the specific content, but in the way in which the guidelines were revised in the process, and the grading in terms of the recommendations deals not only with the strength of the evidence now, but also with the weighing of risks and benefits. And that's important because often when we don't have good evidence, we have strong opinion, but assessing those opinions must be done taking into context the risk and benefit equation, and this is particularly true when you're using anticoagulants and there's always a risk of bleeding. Several key themes emerge, particularly as it relates to thromboprophylaxis. First of all, nowhere do they endorse the use of aspirin as a form of thromboprophylaxis in any patient setting. Specifically, the guidelines say that aspirin is not an acceptable choice for patients undergoing orthopedic surgery. In other words, aspirin may not be used if one wishes to comply with these guidelines. And recall that these guidelines are a major benchmark of quality. Also realize that the Centers for Medicare and Medicaid Services recently published a proposed rule that said they would no longer pay for hospital-acquired DVT and PE. So they are making a concerted effort to focus on this. This stands in contrast to the recent guidelines from the American College of Orthopedic Surgery, the American Academy of Orthopedic Surgery rather, where they recommend that aspirin is an acceptable prophylactic choice. The orthopedic surgery perspective, I think, weighs issues about risks of bleeding differentially, and I think it looks at the aspirin literature a little bit differently and weighs subclinical thrombosis also differently. The current guidelines from the American College of Chest Physicians look at the randomized controlled trials that have included aspirin and say they are very limited, and also look at aspirin as not being an acceptable choice because in clinical trials that have used other alternatives where below-the-knee DVT is an endpoint, you automatically alter that natural history by treating that below-the-knee DVT when you find it. And again, the orthopedic surgery literature or the orthopedic surgery's position statement discounts the value of DVT as even an endpoint in the clinical trial. So there's been a major change there. When it comes to medical prophylaxis, there's also been a substantial change. In addition to the use of unfractionated heparin and low molecular weight heparins as alternatives, fondaparinux, a novel anticoagulant, is listed as an alternative. Realize there is no FDA approval for fondaparinux in the United States. However, there is a randomized controlled trial that supports its use. Individual institutions will have to weigh these issues differentially because, again, heparin, unfractionated heparin, whether it's that form or low molecular weight heparin, have different pharmacokinetic properties than even fondaparinux, and so you have to look at your institution to decide what should be protocolized. And in that same vein, the new guidelines endorse protocolization, they endorse written policy statements for hospitals, and they say hospitals have to take ownership of this. Beyond our traditional choices, we may be seeing emerging a new choice for anticoagulation when it comes to DVT prevention. There are now oral agents under study. Rivaroxaban, which is a new oral anticoagulant. It's hopefully going to be a follow-on to zymogatrin, which was a failure as an oral anticoagulant, is now being studied aggressively. There were 2 articles in the June 26th issue of the New England Journal of Medicine, one focusing on hip replacement surgery patients by Erickson and colleagues, another one looking at knee replacement patients. Realize in these randomized controlled trials with this oral agent, the comparator was not placebo, it was enoxaparin. And what they saw was that head-to-head versus enoxaparin, the oral agent was superior, not only in the combined endpoint of any kind of venous thromboembolism, whether it's below-the-knee DVT or clinically major DVT or PE, but it was actually also superior to enoxaparin when it came to the clinically relevant venous thromboembolic complications like pulmonary embolism and proximal deep vein thrombosis. So that really is a substantial advance because in the past we haven't seen that with one choice versus the other in high-risk settings we actually necessarily make a difference on rates of pulmonary emboli. We realize, of course, rates of pulmonary emboli with both choices were low, and each study included approximately 4,500 in the hip replacement study and then about 2,500 in the knee replacement study, so you have to study a lot of people in a large clinical trial to get these kinds of differences. Beyond that, in terms of getting back to that issue about weighing risks and benefits, in both studies they saw that the risk for bleeding was similar between the oral agent and the traditional low molecular heparin, and so if there is an opportunity to enhance efficacy or improve patient outcomes without compromising safety, I think that's going to be very attractive to us in clinical medicine. We await further trials with the drug for medical prophylaxis, which are underway, further trials that are underway in terms of actual venous thromboembolism treatment, and then in fact other trials in acute coronary syndromes and for atrial fibrillation. So keep an eye on the literature for this new molecule. I think it's going to be very exciting. Hopefully it will be commercially available to us in the U.S. in perhaps 18 months to 2 years, but I'm just guessing there. Irrespective, the field of anticoagulation management took a major advance forward in the last 2 weeks. Lots of new guidelines. The ACCP consensus statement is probably over 800 pages long, and newer choices making their way into the clinical trial literature. With that, hope everyone has a good 4th of July holiday. This is Andy Shore signing off from Washington, D.C.